I'm Dr. Frank Boehm. I'm a professor in the Department of Obstetrics and Gynecology and vice chairman of the department. My specialty is maternal fetal medicine, which is high risk of pregnancies. Regionalization is a concept that originated in the early 70s. It was pushed by the March of Dimes, and we got interested in here at Vanderbilt because we felt that this system, which divided Middle Tennessee into areas that could administer and dispense the kind of care that was not identical in every city. Vanderbilt had all the subspecialists, all of the state-of-the-art equipment, the kind of things that other hospitals couldn't afford or just didn't have the equipment or the personnel to handle. So it was a nice system that would reduce cost and duplication, but more importantly, it would administer the kind of care that patients needed. That meant, though, that patients in the periphery of, say, Nashville and Vanderbilt would have to come to Vanderbilt if they needed that kind of care. And if they didn't, then maybe they would go to a level 2 hospital. So it was the sharing of patients that really initially became somewhat of a problem for a lot of doctors who were not used to sending their patients away. So when they had a problem pregnancy, they could call us. We could consult with them on the phone. They could send the patient in for consultation, or they could send the patient in for care. And that required a certain responsibility on our side, which was to make sure that not only did the patient get excellent care, but that the referring doctor was advised of what happened, the follow-up was appropriate, and the patients appropriately sent back to their doctors.
I've been in Tennessee since 1992, and when I came from Texas, I thought all I needed to do to provide care to the babies in Tennessee and to get Tennessee out of the bottom of infant mortality was to have Dr. Walsh come, and I was going to take these sick babies and resuscitate them, and you guys obviously didn't know what you were doing, and I could change single-handedly infant mortality in Tennessee. Okay, so I now have 22 years of education on that's it, not actually how it works. Okay, it became clear to me it had very little to do with the newborn care, but more with the whole system of care, trying to get the best care to the mothers and the babies when they're born and to the babies after they're born, which took a huge effort that wouldn't be any one person.
The outreach educator is primarily responsible for providing continuing education to nurses in the region. We also help coordinate education for the physicians, either through our own courses or in conjunction with the physicians here. These courses, as part of our grant through the state, we're required to provide education that is of no charge to these hospitals. And I think that is a very important role of this program, because we know that research brings us new information, the way we care for patients changes, and these nurses need to know the latest, greatest evidence-based type of care to provide safe care. I think that the regionalization program would not work at all if we did not establish trust with the providers and the hospitals that are in our region. And you know, they can hear about Vanderbilt in the news, but when they don't have a face and a name and a person that they've met, they're not necessarily going to trust this place to take care of their patients. And so we've made it a priority to visit the hospitals, to visit the provider practices in this region multiple times over the years, because of course some of their people change, and we want to get to know who's out there, what concerns do they have, what ways can we help them besides caring for their patients. Do they need education? Do they need other resources? And so that's been a really exciting part, I think, of this program, is getting to go out and see these hospitals, meet their nurses, meet their physicians, and hopefully establish a level of trust so that they feel really good about sending their patients here when they need to.
When you are a neonatal health care provider, nurse, doctor, respiratory therapist, social worker, physical therapist, when you go to your basic schooling, you really do get a good education, but you really don't often get enough opportunity to become the subspecialist that you need to be to work with these high-risk children. So that we have found that continuing education had to be developed. All healthcare providers of babies need to be current with their neonatal resuscitation education. And also, what do you do while you're waiting for transport, if that's the situation that you're in, is another course called STABLE. So in the beginning, these courses, these structured courses, did not exist. So each regional center had to more or less develop its own curriculum. This was before PowerPoint, this was before that. So we really just had the typical slides, shows, and the technology just for education was not as it is now. But every 5 years, we look at the new knowledge, we revise the objectives, and we modify the modes of instruction so that now we're really pretty much in Tennessee doing what all the other states are doing as well, and using endorsed programs, March of Dimes, AAP, ACOG, to model our outreach education activities.
One of the analogies that we had was I would see a baby floating down the river and I'd swim out and rescue it. And then another baby would swim down and I'd float down and I'd swim out and rescue it. And I got to be a pretty good swimmer and a pretty good rescuer. I'd swim out and rescue them. But there, occasionally some would slip by that I couldn't rescue. And I finally realized what I would probably do better is to find out who's throwing the babies in the river and go upstream and stop that. So I've stopped. I'm a swimmer, but I realize the importance of let's go finding out how can we prevent these problems. I'm very good at taking care of sick babies, but I think we'd be better off having fewer sick babies for me to take care of. So one of my goals is to put myself out of business. I'd like to see smaller intensive care units, less need for intensive care, and that requires a regionalization approach, including the mother and the delivering hospital and keeping the babies healthy from not the time of birth, not the hour of labor, but during the pregnancy, trying to avoid, and some of that might even require making the mothers healthy before they get pregnant. So there's a synergy with, you have all the babies getting excellent care. No matter where they're born in Tennessee, they should get the same care.
Tennessee has really done a wonderful job in the regionalization process. All 5 of our regions are active and working with the goal in mind to improve the outcome for the 80,000 babies that are born each year in this state. And I think we have a lot to be proud of. There are some pioneers in this field, such as Dr. Stallman, other neonatologists throughout the state, as well as obstetricians throughout the state. And it's been an honor for me to be a part of the process.